Hello, everyone. Welcome to Bourne Hall's webinar this evening. My name's Lee Wilmot. I'm the Patient Services Manager at Bourne Hall, and I'm joined this evening with my colleagues, Dr. Charlene and Olympia, who's from Access Fertility, and will be talking to us about some finance options for you this evening. So we're going to kick straight off, and I'll just give you some house rules. So your microphones and cameras are off, but you should be able to see and hear the panelists this evening. At the end of the presentation, there's a Q&A, and we can answer any questions that you might have at the end of the session. So over to you, Charlene.
Okay, perfect. Thanks, Lee. So yes, like Lee said, I'm Charlene Haparachi. I'm one of the consultants at Bourne Hall. Good evening. So this is all about the shared single-sex couples, you coming forward for treatment and all the different options available to you. So first, a little bit about why you want to come to Bourne Hall to have treatment rather than different types of treatment that you might be aware of. It's always better to do it in this type of treatment in a clinic where it's regulated, it's safe, you know that you're being well looked after and everything is being recorded, and it's just basically protecting you and your family in the future. It is more efficient, and we specifically look into legal matters like legal parenthood, which can be potentially quite tricky, maybe not necessarily now, but in the future. And I'll get on to things like the sperm donor rights and the legalities surrounding that later on. So what do I mean by safer? So that we do quite a vigorous sperm donor screening procedure in our clinic. Anyone who comes forward to donate sperm, whether it's altruistically or because they want to sperm share, they need to go through a screening process. Firstly, they need to do a health questionnaire where they need to go through and specifically tell us if there's any medical conditions on either themselves or their immediate family. Anything that is serious, that is either physical or mental health issues that seem to be running in the family, we will then exclude them from being a donor. And so that's specifically for themselves and medical conditions that could be running in the family that might have a hereditary originality to it. We do entry and exit screening, so specifically looking at Hep B, Hep C, HIV, and then other sexually transmitted infections like chlamydia, gonorrhea, and syphilis. And we also look at HTLV. So this is a form of testing, and if that comes up as positive, then they are also excluded from donating. We look at their chromosomes, so making sure that they are normal 46XY, and we also look for most of the mutations or cystic fibrosis. So this is what encompasses our genetic and genetic screening and looking at any inherited conditions. And then we also do screening for the couple who's looking to receive the donor sperm, and that is looking at their Hep B, Hep C, and HIV. Thank you. So legal parenthood, what does this mean? So essentially, when you're using donor sperm, and especially in a couple where we're potentially just using one person's gametes, so specifically in the situation where we're having a single-sex couple, then we need to make sure that the other partner is essentially looked after, and that you're aware that the donor sperm, the sperm donor doesn't have any legal or parental responsibilities over that child. And this is how it's done by doing these forms and safely and legally through a clinic. So if you as patients are married or in a civil partnership, then you are both regarded automatically as the legal parents. You just fill out one form, and then that automatically gives you the right over any child born as a result of donor sperm. If you are unmarried, legally, currently in this country now, if you're unmarried, then we need to do a separate couple of forms, and that is to make sure that the partner whose eggs we're not using can be a legal parent in this family setup. We do give implications counselling that goes through this in much more detail, that talk to you about the different scenarios should you decide to disclose or not disclose how you disclose to a child, and this will also come up later on in the talk, but that is all provided as part of the service at Bourne. Thank you. These are, I mean, you might have come across stories in the newspaper or on social media that discuss these things a little bit, because obviously when people decide to do this type of treatment at home, such as like home insemination with a friend or a helper, then these are the stories that you potentially might see. So this is, I think, a specific case where a woman used a friend to basically donate his sperm to get pregnant. He used it with the famous turkey baster, which I'm sure people have heard of. And then she just thought, because they were friends and he knew what she wanted to do and what she wanted, that he would just be a friend in that child's life. But he actually decided to take her to court and have parental rights over the child, which he did win. Because of course in this situation no forms were signed or anything like that, and there is no other partner or father figure in this scenario, and this is why he was granted these rights. So these are the type of issues that we absolutely want to avoid, and we do so with doing everything formally and right through your specific forms. Thank you. So a little bit about sperm donors and the rights in this country. So a few years ago, the non-anonymity rule was thrown out, in the sense that you as parents or intended parents will be anonymous to the donor, and they will be anonymous to you. But any children born as a result of donor sperm can find out some information when they turn 16 through the HFEA. That's usually to do with health issues. But then when they turn 18, they can actually find out their full name and their last known address. It's kept at 18 because their donor parent does not have any parental, financial, and any responsibility over this child. So this age limit will not be changed, but they are able to find that information out, and the donor is aware of that. So like I said, no legal obligation to those children. They can find out how many children they have produced using their donor sperm, and a little bit about their sex and the year of their birth, but only a little bit after they've donated. They can withdraw at any point their consent to further donation. So they can decide at any point, even if they've decided that they wanted to donate to X number of families, usually up to 10 families is what is allowed. But sometimes they can say, I would only like to produce up to 3 or 4 families, but then they might change their mind halfway through. Whilst they're kept anonymous to the recipients, there are plenty of non-identifying information still available for the recipients to be able to choose who they'd like to use as their donor. So a little bit about their hobbies, about what they do for work, and there's usually a goodwill message there that they can read and also disclose to the child later on if they wish to. Thank you. Next slide. So the different treatment options that you have in a single-sex relationship are, you might have heard of already. So something called intrauterine insemination, or what we call IUI for short. And then there's IVF, and then there's shared motherhood. We'll be going through these different options in a bit more detail as we go along the process. But IUI is the simplest form of treatment that we have. And it is really simply just the introduction of sperm into the uterine cavity, which, to be honest, in most situations in a single-sex couple, this is really what you need, unless there is a particular problem with the partner who's intending to host the pregnancy, such as irregular periods or issues with blocked tubes, then IUI is a fairly simple thing to start off with. There's a bit of a big jump then to the next step of treatment, which is IVF, which is considerably more work, which we'll go through later. And then you've also got the other option of shared motherhood, where both of you can be involved in the process, where one will actually effectively donate their eggs to the other. But I will go through them individually later on. Next slide, please. Okay, so IUI. So what we do, you'll see here on the left, is what we how we monitor someone's eggs. So we've got two ways of doing this. We can do a natural cycle stimulation or medicated stimulation. A natural cycle meaning that we don't actually give you any medications to make sure that you're releasing an egg, because again, if you are having regular periods, you should be doing that naturally on your own. We can still scan you to check that your ovaries are responding like they should be and growing an egg properly. So as you can see on that graph, there is a small little orange dot that's above that black line. So this is the follicle that has been chosen by your ovaries to grow, and a few days later it's growing quite nicely. So this is now at 19 millimeters on that Monday, the 7th of September, for example. It has shown that it's now ready to ovulate. So at this point, we give you an injection to mature the egg and help it ovulate. And so that also plans the insemination process. So 36 hours later is when we call you in to do the insemination. And that diagram kind of shows a little bit about how it's done. It's just we pop a speculum in, and a very thin tube goes through the neck of the womb, and we place the specimen directly into the uterus. So this way we know that then the sperm will then swim into the tubes and hopefully meet the egg in the tube, do the fertilization there hopefully, and then spend the next 5 days going into all its cells, and on the 5th day that's when it'll be ready to implant into the uterus. So all those things will be happening naturally. We're just basically facilitating, making sure that an egg is being grown, ovulating, and then putting the sperm at the right time into the right place. That's a natural cycle way, but sometimes some women's periods don't always play ball, and you can have issues with irregular periods or anovulation, where you're just not regularly ovulating, or just with the stress of everything, some women's periods decide to go off a little bit. So to give us a bit more control, then we can give you a small amount of medication to stimulate your ovaries to ensure that we get an egg. And so that would be the medicated part, where we give you hormones in the form of injections for a few days to ensure we get that. But that will be something that will be discussed at your consultation, and there will be a recommendation from the doctor if one or more is one of them is preferable over the other. Otherwise, it would be a choice basically left to you to decide. But that's essentially how IUI works. By this point, you'll be having progesterone pessaries after the insemination, and then about 10 to 12 days later, you do the pregnancy test to see whether it's worked. The success rates for IUI are roughly around 20 to 25% per cycle, which is essentially what it's like between a heterosexual couple when there are no issues at all, when they're trying naturally. So we would want to say that to give it a fair go, then a couple of cycles would be worthwhile. I think I touch on that a bit later, but usually one cycle is probably not enough to give it a fair go. Up to 2 to 3 cycles would be something that we would normally recommend. Next slide, please. So why IUI is probably more efficient than the home insemination process. Obviously, this way we are screening the sperm and also making sure that the ovulation to insemination is all regulated. When an egg is released, it is only around for 24 hours. So it's just because we are tracking you for this egg to be released and giving you medications to help it be released, and then timing the sperm to go in at the right time. We know that this is all going to basically maximize your chances of egg and sperm being able to meet and therefore fertilize. We know that intrauterine placement of sperm is much better than intravaginal because it's already done half the job, half the pathway for it to go to the egg is there. So it's gone past the cervix, got past all the cervical mucus, which there are some theories to suggest that can be a potential problem for natural conception. So it kind of bypasses that barrier. Hormone drugs, so I mentioned in terms of the stimulation, it can improve success when you're not potentially ovulating yourself, because it gives us a bit more assurance that you are releasing that egg, which is what the last point also signifies. So next slide, please. And then I mentioned, so the next step is IVF. So it is a bit of a big jump between these two treatments, and that's true as for a single sex couple or for a heterosexual couple, whatever. There's no in between. between IUI and IVF. The IVF is the next form of treatment, which you may know a little bit more about. It's becoming more and more common. Everyone knows usually someone who's gone through the IVF process. And how that works is because we are putting several eggs through the process rather than just the one. So in IUI, we're still trying to mimic what would happen naturally by growing one egg. But in IVF, we want to put several eggs through the process. So you can see on that graph now that the aim is to give you high amounts of drugs to grow lots of eggs, ideally somewhere between 6 and 12. And so you can see this black line signifies the recruitment of the follicles. And if it's above that black line, we know that it's starting to stimulate and responding well to the medication. So if we give you medications for a good 10 to 12 days in the form of injections. So you have a few different appointments now. There's, I should say, IUI, there's probably about 2 or 3 appointments to the clinic, one for a scan, one for the insemination. You might have a second scan just in case the growth of the egg is not going as well. In IVF, it's probably double that, maybe 5 or 6 appointments, because we need to have 2 or 3 scans as we're doing a lot of stimulation of your eggs, and we just want to make sure that that's going along okay. And then when we're happy with the size of the leading egg, like it is in that second column of those dots, that's when you come forward for the egg collection procedure. So the egg collection procedure is a minor surgical procedure. So you'll see on this ultrasound scan image at the top here, this is what your ovaries look like when you're ready to have your eggs collected. Those big black circles are the eggs. So they're much bigger than what they would be naturally. And we essentially go in vaginally with a long, thin needle. The needle pierces the follicles and we aspirate, so suck out the fluid that's in each of these follicles. Goes into a test tube. The test tube then gets read by the embryologist, who's just sitting behind us, and they'll be able to tell us how many eggs we've managed to get from you as we go along the process. The egg collection procedure takes about 10-15 minutes. You'll be in the theatre for about half an hour because it is given under local anaesthetic and conscious IV sedation as standard. But there is always the option to have an anaesthetist present to be put to sleep if you prefer. And then you'll go back to our recovery area for about an hour just to make sure that you're eating and drinking and feeling okay, and then you need to be driven home. On that same morning, the donor sperm will have been obviously already assigned and thawed out. So now that we've got egg and sperm, and they will go ahead and do the ICSI process. The ICSI process is where they inject the sperm directly into the egg. This is most likely going to be done in a situation of IVF when we're using donor sperm, mainly because the donor sperm is usually frozen and thawed. So therefore, they're a little bit lazy when they are in that process. So to make sure that they fertilize the egg well, they do the ICSI process as standard, injecting the sperm into the egg to try and get a good fertilization rate. Leave them overnight, and then they get back to you the next day to tell you how many embryos you've managed to have. So if you see in the box at the bottom, you can see kind of like the progression of these embryos. On day 1, all the embryos look the same. They're just one big blob. So it's really difficult to know between them which is the one that's going to be the one that has the legs to carry on and hopefully give you the best success. So what we'd like to do at this point is grow them to day 5, ideally. This is what we call a blastocyst culture. So this mimics what would normally be happening in your fallopian tubes. They go from 1 cell on day 1 to hundreds and hundreds of cells big on day 5. On day 5, they're then graded A, B, C, and D. As you can see, this blastocyst, this picture on the bottom right, this is now an expanded blastocyst, and this is at the stage where they're ready to implant into the uterus. So then we would be looking to do the transfer, which is very simple. It's a bit like a smear test, where we pop a speculum in and a very thin tube through the neck of the womb and we place it under ultrasound guidance. This bit only takes a couple of minutes. And that's essentially the end of the process. I mean, by this point, you'll have stopped all your injections. You'll be on progesterone pessaries for the next 10 days until you do a pregnancy test. And if you have a pregnancy test which is positive, you carry on with the progesterone pessaries until about week 8. So quite a few more steps involved in the IVF process, probably about 5 or 6 visits to the clinic, and it's 6 weeks from start to finish. But because there's a lot more work involved and we are maximizing chances by having lots, it's a bit of a numbers game. So we've got lots of eggs, therefore hopefully quite a few embryos, and therefore the choice to be able to put the best one back. It does increase your success rates considerably to about 45 to 50% per go. That's probably enough. I don't want to overwhelm you about IVF. That's probably the next slide would be great. Thank you. So this is just a little kind of like comparison between IUI and IVF, what it means. So fallopian tubes, that's an important thing I didn't mention earlier. In IUI, we need the fallopian tubes to be working because this is the major connecting mechanism between egg and sperm. So when the ovary releases the egg, the tube picks up that egg, and then sperm is put into the uterus. And so the meeting place is still as it should be naturally inside the tube. So we would ideally want to check your tubes before you start the IUI process to make sure your tubes are open, allowing this treatment to work. In IVF, because we bypass your tubes, you don't actually need to know what the assessment on your tubes is like. So whether it's blocked or open, we can do the IVF process and bypass it. In IUI, it is very simple procedures, a simple type of treatment. The most invasive thing is the insemination process that involves the speculum. The tube that goes through the neck of the womb is really tiny, so you really wouldn't feel that. The IVF procedure obviously has a bit more of an invasive element to it. Egg collection is a surgical procedure, albeit a minor one, but it does involve a needle going through the vaginal wall into the pelvis. So there is a bit more work involved there. In terms of success rates, already mentioned about 20% after one cycle. So cumulatively with IUI, after 3 cycles, we say 50%, but then you'll have the similar success rate after 1 cycle of IVF. So that's why we say give IUI a good go with 3 goes really before thinking whether you wanted to move on to IVF, just to see whether IUI is something to give it the benefit of the doubt and to see if it will be successful for you. I think unless time is of an issue, which obviously that is age dependent, then we tend to say 3 cycles. Certainly up to 6 cycles is also very, very common, but after 6 cycles, we really would be suggesting that it's not work. If it's not worked for you by this point, to not take any more time doing IUI and go to something like IVF, which is much more successful. Multiple pregnancy is always a potential risk when it comes to any type of fertility treatment. IUI, it is less so because we are trying to control for it and only trying to grow 1 egg at a time. 1% of pregnant women, if it's a natural conception, so this is usually because of identical twins, so when 1 embryo splits into 2. If you're medicated, then there is a small chance that your ovaries might get a bit excited and grow a 2nd egg. In this situation, then there is a higher chance of you falling pregnant. And we've quoted here 25% of pregnant women potentially could have a multiple pregnancy. If there are 2 follicles growing, we're happy to continue. If you're happy to continue, knowing that chance. If there are 3 follicles or more growing, then we would be cancelling that cycle. The risk of triplets or higher is just too risky, and we really would. It's not the aim of our treatment at all. So that would be the only reason we'd be cancelling, because of the risk of multiple pregnancy. Similar in terms of IVF. Again, we're much more in control of embryos because we're going to be putting the embryos back into you. If we put 1 embryo back, is a 1% chance of multiple pregnancy. If that 1 splits into 2, which can happen naturally, or whether it's an IVF, that splitting happens after it's left the lab, so we're none the wiser about that risk. But of course, if we put 2 embryos back, then if you fall pregnant, there is a 25 to 30% chance that you can get pregnant with a twin pregnancy. Statistically, 2 can become 3 or even 4. Now, we've never seen 2 become 4 in our clinic before, so that's okay, but we have seen 2 become 3 on occasion. And triplet pregnancies, again, as a result of IVF, they do tend to be quite tricky pregnancies. So we really would be talking to you about what we would be recommending in terms of 1 or 2. We never put more than 2. The choice is always between 1 or 2. In younger couples, when this is technically your first cycle, we would always be recommending 1, just to see how you get on. 2 is more so recommended if they are slightly poorer quality embryos, or if you've had a couple of cycles and it hasn't worked with 1, or if you're a bit on the older side, just to boost your chances. Storing of the extra embryos, this is only something that can be done in IVF because, of course, we're making lots of embryos, hopefully. And if we have any surplus good ones, then this is a situation where we can put 1 into you and then potentially store the rest. We can freeze them for up to 10 years. Freezing is a little bit of a bonus. It really is, depends on the situation, the age of the woman going through the process, and also the ovarian reserve and the number of eggs we manage to get from you. But that is a possibility in IVF, but of course it's not in IUI, because in IUI it's more of a natural process, and we're trying to just grow an embryo inside of you and therefore implant inside of you. The cost, because of the amount of work that's involved between the two, and they're quite different, the cost is quite variable. It's quite different between the two. IUI, don't quote me, probably shouldn't say this, but it's roughly £1,500 per cycle, I believe. And then with IVF, we're looking at around £7,500 to £8,000 per cycle. But this is excluding donor sperm costs, which would be on top. So you can see it's much higher in IVF compared to IUI, but we're hoping that IVF, because it's the chances of success are much higher in one go. It could be that if you're lucky with IUI on one go, then that's great. You would have saved quite a bit of money. But there are situations where you might have tried IUI several times, which actually would have equated to the same price of IVF. So it really just depends on your situation and what you feel more comfortable with how you want to start. But this, if you decide to come forward for treatment, this will all be discussed with you in much more detail at your initial consultation. And we can go through that with you, and you can decide which way you want to start with this. Next slide, please. So a little bit about how we decide which way to go. Of course, your opinion comes into play a lot, but when it comes to which way, things like AMH and age come into it. So if your AMH is good, so AMH stands for anti-Müllerian hormone. It's a blood test to check your ovarian reserve. If your AMH is good, indicating that you have a very good ovarian reserve and you're on the younger side, then IUI or IVF is absolutely fine. IUI is a perfectly reasonable thing to start off with. And if it doesn't work after 2, 3, however many cycles, up to 6, then you've got the time on your side to then go on to IVF. If you're on the older side and your ovarian reserve is still good, then because time is not necessarily plentiful, unfortunately, because of the age effect on the eggs and quality, we really would be recommending to explore IVF rather than IUI, just because it is a higher chance of success and we want to do it as quickly as possible for you. 40 seems to be quite the age where the egg quality really does dip quite considerably, but we do notice that the egg quality starts dipping a bit earlier, usually around 37, 38. So you'll notice that many clinics, including ours, differentiate their success rates of IVF just generally in women who are 37 and below compared to those of 38 and above, because we do see a bit of a borderline there. And next slide, please. And then this is then similarly, if we're looking at your AMH test and it's come back as poorer than expected or on the lower side, then we would bring that kind of threshold to consider IVF much sooner. So 35 and younger, fine. You might want to try IUI because it's less invasive, cost, cheaper in terms of costs, and these are all very valid reasons as to why you'd want to try that. But we really would want to make sure that you are young, on the younger side, because then the egg quality is as good as it can be. But the minute you turn 35, we really would be suggesting to go down the route of IVF. The extra little diagram there for women who are 38 and above, and if the AMH is on the lower side, then yes, you can consider IVF. But then actually in your scenario, there are 2 of you. And of course, if there is a situation where one is younger than the other, then the shared motherhood option could be an option for you, where one of you who has a reduced ovarian reserve could be the one that hosts the pregnancy, but the other one could be donating the eggs. I think I'll go into that in a bit more detail later. Next slide. So I think I've covered this already, really, with IUI, but we obviously don't do the whole donor sperm matching like we would with IVF and IUI. That process is at the start already. We always have to make sure the donor sperm is all sorted and in the lab matched to you before we can start any type of treatment. But we give you the medication, or we do an actual cycle, and then we pop the sperm back into the uterus. This diagram is just saying that we often say between 3 and 6 cycles is what we recommend and what's probably most common that couples would try. There is no, definite. You can do it just once, you can do it twice, that's fine. Or, if you really want to do it more than 6 times, that would require a conversation. There's nothing stopping you. If you really don't want to go down the route of IVF, then of course IUI is the way that you would keep going. But if you are considering IVF, then we would tend to say limit it to up to 6 times, because if it hasn't worked by that point, maybe then going on to IVF, which does have a higher chance, would be beneficial at this point. Next slide, please. Okay, so shared motherhood. So basically, this is where, like I mentioned, so one of the partners would be doing the first bit. So we'd be giving you hormones in the form of injections to grow the eggs. You'll be the one that has the egg collection process. Once we collect the eggs, then your treatment effectively stops. We wouldn't need to give you any hormone medication in terms of progesterone. We get the eggs, thaw out the sperm, make the embryos, do the same process of growing them to day 5, and then we pop it into the partner. So your partner will be essentially hosting the pregnancy and delivering. So we would have given medications to the partner synchronously, like usually at the same time, to get the lining right so that it would be receptive for the embryo. That is the way that we most often do it. If you don't want to do it at the same time, then that's fine. What we can do is we can make the embryos, freeze those embryos, thaw them out, and then at a later time pop it into the partner where they're going through their treatment later. And so that it drags out the treatment a little bit more, but if that suits you in terms of timing, that's absolutely fine. But I'd say that most commonly they want to do it synchronously at the same time. You would be having, if you want to think about exploring the shared motherhood option, then you will be given a double appointment with the doctor, because there are, as you can imagine, it can get a bit confusing, because we'd have to talk to each of you as a patient and then as a partner, and we'd have a lot of forms that we'd need to go through. So there will be plenty of time to go through this treatment option in much more detail and get everything right, so there's no confusion when you come forward for treatment. Next slide, please. In terms of regulations around shared motherhood is essentially a relatively new concept. There isn't too much on the HFEA about it. The HFEA is our regulatory body for IVF, so they haven't really given strict rules about it as much, but what they have said, that a partner providing eggs to their other partner, then they need to be screened as a donor. This doesn't really apply to heterosexual couples, because that doesn't happen. But when they are donating their eggs to their partner, they will need to be screened like as if they are being an anonymous donor to an unknown couple. So that means you'll be screened with all the HIV, Hep B, Hep C, the chlamydia, gonorrhea, syphilis, and looking at inherited disorders, chromosomes, and cystic fibrosis. But the difference is that if one of the donor screening tests comes back as abnormal, what do we do? In a situation where you're using donor sperm or donor eggs in an anonymous situation for another couple, then of course they will be straight away excluded. But of course, between a couple, it's a bit more lax. It's a bit more relaxed between the two, because of course you know about it, and you're with each other. So we talk about what the extent of the abnormality is. If it is something like a low AMH, so we know that there's going to be a reduced number of eggs, or if it's going to be something really quite simple that is compatible with life, then I'm sure you'd be fine with it, and as long as it's all documented and out in the open, it's fine. If it's something like cystic fibrosis, so if the donor in the couple was picked up as a carrier for cystic fibrosis, then we know that the donor sperm would have been ruled out for any cystic fibrosis. So therefore, in this situation, if you were to continue, then there is a 25% chance that the child will also be a carrier. So just like the donor, so one of the partners in the couple. This might be a bit complicated to explain and to understand now, but it's just to say that if you are happy with that, and as long as it's okay and it's not really, it's viable with normal life, which it would be because the partner already has it anyway, then then we are very happy to continue. So I guess it's just saying that the rules are a little bit more relaxed as long as it's well documented. You know what the risks are and what they entail and what the statistics are, and we can carry on. I hope that makes sense. Next slide, please. There is the option, if you wanted to, both of you go through treatment at the same time. So potentially, I mean, both of you either having donor sperm and going through the treatment in terms of stimulation of the eggs and having the embryos put back into you. I have to say that this is not very common, and we tend to go against that just because it is very invasive work, and the person who's already going through it would like ideally the support of their partner, which is true of anybody going through this process, and usually a good support network around them. If both of you going through it, then you can imagine it'd be quite a difficult time for both of you. But it's not a no-no. It is something that some people might want to do to quicken up and then to kind of like get through, maximize their chances of falling pregnant and to complete their family quicker. But ideally, it's more manageable for both the patients and for us if a few months were between the conceptions, ideally. Next slide, please. I mentioned a little bit about implications counselling at the beginning of the session. When you're using donor gametes, so in your case donor sperm, it was really important to have implications counselling, just so that you can understand what the implications are when you're using a donor, how to disclose it to the child. If you do decide to disclose it to the child as intended parents, it's your decision completely, and dealing with difficult questions as to how you would manage, what difficult questions the child might pose later. And sometimes it can be, now we're getting into a world where it's becoming more and more normal. And I have to say, this is probably more taboo in a heterosexual couple where they're potentially trying to hide if the child has come from a donor gamete, not necessarily applicable to a single-sex couple. So usually much more open, but it would be good to have this counselling session where you can go through these different scenarios. They come into hand, like they're very good with explaining what books to use, at what age to do it, and different scenarios as to what would happen if you don't disclose, and with the future child want to learn who the donor was, so how to basically answer these questions. And this is all included as part of your treatment, just to have that hour-long counselling session. Either you can do it individually or as a couple, however you prefer. Next slide, please. Right, so I'm going to go on to a little bit about funding, and this is where my colleague Olympia will come into, but I'm just going to kind of introduce it. So there are a few different ways that you can pay for treatment. One way is a simple way that you can just directly pay for one cycle of treatment at a time, and that will just be paying directly to the clinic. There is a way you can be doing it going down the route of egg sharing. So if you are an egg sharer, then essentially you are keeping half your eggs for your own treatment, and you are donating half the eggs that you grow and collect to the egg bank so that someone else can use them in a situation where they need donor eggs. In this situation, you can receive compensation for your form of treatment. It does definitely reduce the expenses of your treatment, but you'll have separate counselling for this, and you'll have to accept that obviously you're donating half your eggs away. NHS funding for single-sex couples, it's a bit of a grey area. I'm not sure the CCGs have really come up to speed with that. I think there are certain CCGs that do offer it for single-sex couples, but only in situations where there is another separate issue why you might not be falling pregnant, for example, like blocked tubes or problems with ovulation. I don't really know that you'd have to inquire through your GP, be referred to the secondary care hospital, and I think there are other stipulations like needing to self-fund rounds of IUI before you're eligible for IVF. But it's definitely something to look into, because IVF, as we said, is expensive treatment, and if it's available in your area and you're eligible for it, then it's definitely something to look into. And then there are the packages. So if you do decide to come down the route of self-funded treatment, and you like the idea of going into a package, because if you go into a package, then it does make it cheaper compared to paying them individually directly to the clinic. And I won't go into that at all, because I'm sure that's all Olympia will be talking to you about. So I'll move on to, I'll let Olympia talk now.
Thank you, Charlene. Hi, everyone. Good afternoon from my side as well, or evening, should I say. So my name is Olympia, and I'm here on behalf of Access Fertility. And today we'll have a look at some of your treatment options in partnership with the Bornhol Clinic. So let's get started. Next slide, please. So our first program is the refund program, and that will cover you for up to 100% refund if you don't have a live birth under one of our programs. This will also offer you up to 3 egg collections, so 3 full cycles. It offers unlimited frozen embryo transfers, allows you to fix your treatment fees, and it is available to all patients under the age of 40 who are using their own eggs. Now, there's 2 important things that patients need to remember with our programs. So the first one is that your initial consultation, your pre-treatment bloods and scans and medication are not covered under the program. So these will be paid directly to the clinic. And with all of our refund programs, there's also a medical review that needs to be completed. So what we would do is we would request the tests you've already had at the Bornhol Clinic, and then our in-house medical team would have a look at those and check for eligibility. Next slide, please. The next program we offer is our unlimited program. And this one, rather than being cycle-based, it's more time-based. So it has a fixed 100% refund. There are no other refund percentages. And as I mentioned, it's more time-based rather than cycle-based. So this one would cover you for unlimited IVF fresh cycles over the course of 2 years. It will, similarly to the refund program, cover you for unlimited frozen cycles over the course of 2 years. Allows you to fix your treatment fees. And it is available to all patients under the age of 38, so up to 37, using their own eggs. Similarly, the initial consultation, pre-treatment bloods and scans and medication are not covered. And then this program is also subject to the medical review, which I forgot to mention as well. It does take around 2 weeks for that medical review to be completed. But aside from that, we don't have any waiting times. Next slide, please. And our last program, which is the multi-cycle program, and that one is a cost-saving package. So there's a potential saving of at least 1/3 when going ahead with this treatment. This package offers you up to 2 egg collections, 2 full cycles. Again, it covers you for unlimited frozen embryo transfers, and it allows you to fix your treatment fees. And this program has a higher age threshold, so it's available to all patients under the age of 45 who are using their own eggs. With the multi-cycle program, there are 2 differences. So for this program, there is no medical review, so all patients will be accepted onto it. And there is also no refund element to it. So it all covers you for the exact same inclusions, it just doesn't have the refund to it. Next slide, please. And here, just to summarize the key benefits of patients going through Access Fertility, again, it does allow you to fix your treatment cost, which should result in savings within your treatment. It will cover you, it will offer you up to 100% of your money back if you don't have a live birth. And it also offers you peace of mind as you have an additional choice. Next slide, please. So here we see depicted the referral pathways. So there's 2 referral pathways for patients. You can either find Access Fertility organically and have a look at our website, or you can visit your clinic where they will provide you with a leaflet and with information. Either way, if a patient is interested in proceeding with us, one of our patient advisors would register you either over the phone or via email. The registration process is very quick. Then we would send over consent forms for you and, if applicable, for your partner to sign, which everything is always signed electronically, so it's very quick. Then we would contact your clinic, which they would share your medical information with us. And if eligible for the program of your choice after these 2 weeks, you would be able to make your payment through our portal, which the payment with us is made electronically through our patient portal, or it can be done via bank transfer. And once you're enrolled, you would begin your treatment with the clinic as normal. Now, in this case, with us, you would either hopefully have a baby, or if not, you would be able to get up to 100% of your money back. Next slide, please. And here we have some of the most frequently asked questions. So are programs compatible with shared motherhood? So as Charlene touched on the subject of shared motherhood, I also wanted to say that yes, our refund programs and our multi-cycle program are also compatible with shared motherhood fully. It's just that one patient would have to go through the egg collections for the whole duration of the program. So if you choose to go ahead with the 3-cycle, one patient would go ahead for all 3 egg collections, and then the partner would have the embryo transfers. Next slide, please. Can patients have additional services that are not covered by Access Fertility? Yes, of course you can. It's just that those additional services would then be paid directly to your clinic, and they would be based on the clinic's in-house price list. Next slide. Now, how is payment made? So payment is made in full via bank transfer or online patient portal. And it's important to remember that payment to us has to be made before starting your treatment. And that is all from me. I hope you found this helpful. Lee, I'll give it back to you now.
Thank you, Olympia. Okay, so in terms of further information and next steps, you can get in touch with us via email. You'll find that on our website, or you can give the patient services team a call on that number 01954 717 210. And, or as I said, or you can email us at info@bourne-hall.com. Thank you. So the next session is our questions and answers session. So I'm just going to stop sharing so I can talk to you about some of the questions we've already received. Some of the questions have been pre-submitted. So the ones that we've already received, this one's for you, Charlene. I'm currently taking the contraceptive pill Rigavidon.
Yeah, Rigavidon. Yeah.
How long do I need to be off this before I can start treatment?
Yeah, I mean, it kind of depends a little bit about how long the lady's been on that already. I would say probably been on for a while as a form of contraception, or keeping the periods so that they can be managed. So ideally, if you can stop it for at least 3 months, would be worthwhile, just to get some kind of resumption back of your periods, because it all depends on the periods. We need the periods to be back to a fairly regular pattern before we can start again. But sometimes it can take up to a year for those periods to return, depending on how long you've been on the pill in the first place. So if a lady's been on a pill for several years, it might take a little bit longer than 3 months. You can obviously have the initial consultation and the workup beforehand, but we would like to see a resumption of a couple of cycles before we get started.
Okay, thank you. IVF or IUI, what is the average cost if using the host's own eggs or one of the mother's own eggs?
Yeah, so very, very roughly, IUI is about £1,500 per cycle, I believe. I don't know, Lee, if you have any better advice on that, then you might want to jump in there.
I think you're right. I haven't got the precise figures, but yes, that is in the right ballpark.
And then IVF is roughly £7,500 to £8,000 per cycle. But this is using your own eggs and actually based on using own sperm. So in situations where you need to use donor sperm, the donor sperm cost would be on top, which I have to say, I can't tell you on top of my head because I think it's changed fairly recently and I don't want to mislead you. But you could always inquire with the clinic and they can give you a rough cost base of what that would be.
Yeah, thank you. And at the time of from initial consultation to starting treatment, what does that look like?
It's really quick with our clinic, to be honest. There is no waiting time to actually get started with treatment. From the initial consultation, of course, we will want to discuss certain things like preliminary tests. So things like before IUI, we will need to check your fallopian tubes. We might need to do some specific blood tests. Things like thyroid function test is something quite useful. So you get given a lot of information when you inquire with the clinic about treatment, and you get given what tests we'd like you to get done beforehand. So it just saves a little bit of time. If no tests have been done before the initial consultation, then we might need to spend a month or two getting these done. Getting sperm sorted is also probably one of the bigger ones that maybe a delay that will probably that has to happen before treatment. But once all that has been sorted, and it usually takes 1 to 2 months to get sorted, then we can just step in with your next period. There is actually, there is very little waiting time when it comes to actually getting started with treatment in clinic.
Okay, thank you. There's a question about BMI. Is that a big factor for self-funding IUI? Would the clinic consider a BMI of 36.5 if that person is aged about 34?
So we do have a fairly strict threshold when it comes to BMI, and so for NHS funding, that is very strict at 30, but for self-funding, we do relax a little bit on the BMI, but it goes up to 35. And so we wouldn't be able to get started with treatment until that BMI is 35 and below. It's mainly for 2 reasons. One, for safety, just for you to make sure that you are in the safest possible optimum condition to have on a treatment and to have pregnancy, but also the drugs work much more effectively when your BMI is lower. Just it is more likely to work, and there's also a reduced chance of miscarriage the closer your BMI is to 30. So we really want to make sure it's below 35 before we start.
Okay, I can answer this one. Is the counselling a virtual or in-person appointment? So the counselling session is offered virtually, so that has continued since post the pandemic, and it seems to suit patients better that way. But if you did want an in-person appointment, that could possibly be arranged, but you probably need to request that. If only one partner wants to undergo treatment, does the other partner have to undergo any tests, even if they categorically do not want to be pregnant?
Interesting. So even IUI and IVF, if one partner does not want to be involved, so obviously partner A, let's say, just for ease sake, is using her eggs and they're using donor sperm, note that the partner B doesn't need to be involved in any way in terms of medical procedures or blood tests. We don't need to do blood tests on partner B either, but they will need to be involved with paperwork, and because it's to do with legal parenthood. So if they want to be involved in the family unit and be one of the legal parents, then they will need to get involved and be part of the paperwork process, but they don't actually need to have any procedures done themselves. No.
Okay, there's a question here about how painful is the egg collection?
Yeah, I mean, it's not, I mean, it does involve a fine needle that goes through the vaginal wall into the pelvis, so it doesn't sound particularly pleasant, I agree. It's nothing compared to childbirth, so if someone's had a child before, then this would be a breeze. It is very quick, and it is done with plenty of pain relief options on board. Most women get on absolutely fine with the local anesthetic and conscious IV sedation. The general anesthetic option is available mainly for if there is a medical indication for it, because if the ovaries are very difficult to access, or if there's cysts in the way, or if you've got endometriosis, that makes things very much more painful, or we have to put a lot of pressure. Or if the woman does find intimate examinations very difficult, so things like speculum smear tests, or if they're needle phobic or just very anxious about the whole theatre procedure, then you really wouldn't be having a fun time during the procedure, and you being anxious then, you know, does affect the ability for us doctors to do the egg collection thoroughly and properly for you. We want to do the best by you. So maybe in these situations, this is when an anaesthetist might be worthwhile considering. But the pain relief options that we give you in conscious IV sedation and local anesthetic should take away anything sharp. You will be awake and aware, and you will feel prodding and pushing at most. It does come down to a little bit about your own threshold in terms of pain and what you can handle, but it should not be painful.
Okay, thank you. I've got a couple of questions here about sperm donors. One is a question about whether or not there's a shortage of sperm at the clinic. I don't know whether we can answer that one, Charlene.
Yeah. I think actually during COVID pandemic, it did take a bit of a dip, to be fair, but I think it seems to have recovered quite easily now. So we've got lots of sperm donors and their choice available in our clinic. So there are two ways you can go about doing this. You can go through our internal sperm bank, which uses sperm from men locally, but within the East Anglia region usually, where they are either altruistically donating or they're going through IVF themselves with their partner, and there's no problems with their sperm and their sperm sharing. Just like you can egg share, they can sperm share. In this situation, you will be going through a matching process where we send you a characteristics form, and there's a column for the partner A and column for partner B, and that's essentially just for physical characteristics. So you can tick what your hair color is, eye color, skin tone, a little bit about your nationality or your height, weight, etc., just so that we can best match you. And then there's a third column for what you'd be willing to accept outside of your characteristics in the sperm donor. And then that, with some blood tests, will go to our embryology department. They will get in touch with you, usually within a couple of weeks, to talk to you about what options are available in our sperm bank. Usually there are quite a few different sperm options available to you to try and obviously the more criteria you tick, the wider the search it will be. And with those options, you'll get a little bit more non-identifying information about these donors. So like I mentioned earlier, about their hobbies and things, what they do for a living. And then hopefully that'll be enough there'll be something there for you to choose. If, let's say, we don't have anything available in our sperm bank, or nothing takes your pick, then you can go down the route of an external sperm bank. And there are lots of external sperm banks in the country or outside, like in Europe or US, that you can, and our embryologists can guide you with where to go, because there are a list of banks that we like you to use because they have the same regulations as our lab, and so we can transfer gametes between the labs fairly easily. And then you just get the sperm from that bank, and then we need to organize transfer of that sperm into our lab before you can start treatment. But they're the two different ways, but most couples, I would say, get sperm from our internal sperm bank.
Thank you. I've probably got time for one or two questions on the finance front. So Olympia, what happens if patients naturally fall pregnant?
So there are two options here. And the first one is the patient can withdraw from the program, which means that they will receive a partial refund for any unused treatment. And the second option is simply to remain on the program. Now, what we advise as Access Fertility is to remain on the program for as long as possible for a patient to maximize their chances to remain on the program afterwards if they wish to. So they can take a little bit of time, but if they do want to withdraw, they can still get a partial refund from us.
Okay, and can the patient or partner choose to go ahead with egg collection?
So from the beginning, once a patient and a partner choose to go ahead with Access Fertility, as Charlene said, I'll use the same example. Let's say patient A is the one who will undergo the egg collection. Unfortunately, that cannot change for the whole duration of the program. So patient A would be the lead patient who will be going through all of the egg collections. However, patient B can then go ahead and have the embryo transfers. Now, with the Shared Motherhood Scheme and Access Fertility, when it comes to the embryo transfer, the patient and the partner, so A and B, can choose whether they want to have the embryo transfer. So the patient A is the one who will always go through the egg collections, but when it comes to embryo transfer, patient A and B can decide. So it can be either or.
Okay. Thank you very much. If we haven't managed to get to all of your questions this evening, please do contact us at the clinic with the contact numbers that we gave you earlier. But I think that now wraps up the session for this evening. Thank you very much for joining us, and we'll say goodbye. Thank you. Goodbye.